I wish I could just finish this talk in one, because despite extensive literature search, what I find really positively is there is no consensus on IOLs in uveitic eyes. But if I have to say something, then if you were to look at pediatric uveitis, it's very rare disease in children, but you have all these, starting from pars planitis to sarcoid to cat scratch disease to toxocara to Behçet's to toxoplasma. You see everything in children. Rarely, but you do see everything in children. But you have all of them on one side, and you have JRA or JIA on one side, because they are two different things. And when you look at cataract surgery in the spectrum which I put earlier and this, it becomes totally, it looks like you are looking at two different diseases. So you really can't put everything in one basket when you say uveitic cataract. They behave differently. So what are the causes of cataract in uveitic eyes? Sometimes inflammation itself, posterior synechia, formation of posterior synechia is a risk factor for developing cataract. And of course the medication, the steroid, the mainstay of treatment for any inflammation in the eye itself is cataractogenic, and more so in children. So when you do look at doing a cataract, when you feel that it's visually significant and needs to come out, pre-op preparation is very essential. You have to always remember that eye is a part of a systemic disease there, and systemic disease needs to be under control, and there should not be any active inflammation going on when you do consider cataract surgery in these children. So you need a good control of systemic disease, whatever the inciting cause, and you also need a good control of inflammation prior to, at least 3 months prior to surgical intervention. Pupils. Now look, when you come to surgery, finally, your pressure points are these. You have pupil which is not dilating, you have capsule, you have to decide on IOL, and you have to also deal with posicapsule and vitreous. And there is a huge amount of dilemma about whether to do vitrectomy, because some of them do have significant vitritis, and you can induce traction by doing your anterior vitrectomy. So you have to weigh the balance between visual axis clarity versus causing other problems like tractional retinal detachment. So let's look at pupil. You can have poor dilatation of synechia, you can have cyclitic membrane, and the hooks, role of hooks, both a Kuglen hook and a Grishaber hook is probably is indispensable. Then when you look at the actual capsule, it has both. You can either have a friable capsule which tends to run away at the first nick, or you can have a tough and fibrotic capsule which you can't do anything about. So both, sometimes there is total cataract, there is absolutely no view, and it helps to have trypan blue, made life easier for everybody, but especially in this particular group where it is absolutely essential to have some kind of a bag. And it definitely helps to have a cohesive visco device in this situation. Even if you have a free patient who cannot afford, probably it's better as a surgeon that you pay it out of your pocket and use a cohesive in this particular situation. So this is what I meant by a thick fibrotic capsule where you just can't do anything about it. So there probably you have to use an intraocular scissors like my colleague here is using, and probably just use that small opening to take out the lens, put the lens in, and good thing is it won't extend either. So you can really make a small envelope or a very small opening. Nucleus is almost always soft and can be aspirated. Then you have this, where you have a really plastered iris on almost 360-degree plastered. You have a cyclitic membrane right there which has to be cut separately before you can even put the hooks. And it's very good instruments to have a retinal setup along with you, and you can use their instruments because most of them go through a nice 21 gauge settings. You can use their scissors, you can use their forceps. They are never happy about it, but you can use it. We have a running feud with VR department who feel that we all make their scissors blunt by using it. these situations. But here when there is plastered, then before you put the hooks, remove the cyclitic membrane, and it's good to have these Grishaber hooks which go through even a 26 gauge. I don't use side entry knives to make those incisions. You can do it very well. As I said, indispensable to have a stain, and sometimes it's just easy to do a small rexis first and aspirate the lens out, decompressing as you are going along, because sometimes it's so much intumescent that it will extend your capsule. So in between, it's good to have saline cannula and have it. And then you can enlarge your capsule to a further, you can do a second rexis along with it too. Here, this case, I had the permission from our UVI department to do anterior vitrectomy, so I did in this case. And the principle of anterior vitrectomy is same, that you use your highest cutting speed so that you don't induce unnecessary traction, and use your highest cutting rate what your machine offers. And I was able to put the lens here in this case in bag. And I used a single piece acrylic foldable lens in this, and it's a fairly easy lens to put and does behave when it goes in. And so that's basically the principle of surgery in these patients. Now, if coming to the actual topic, what exactly, if you look at the IOLs, what is exactly where you are going to put it, where you're not going to put it, it's really the elephant in the room. Nobody knows exactly if that's the right thing to do. If you were to ask me, yes, it is complicated. It is complicated. If I did a literature search, and if you look at the hard evidence, this is the problem with the evidence which is there in the published literature. Majority of the studies are small case series which are retrospective in nature. There is a lack of long-term follow-up. The maximum follow-up I found was 6 years, or probably another study which I found 7 years, which if you look at a 10-year-old child who is coming to you, 7 years means he's still going to be only 17. So this is the problem with the evidence when you say why it's so difficult to say put IOL or don't put IOL. And there are absolutely no randomized controlled studies which are available which look at leaving the patient pseudophakics versus aphakics. But as a general rule, visual outcomes were better in pseudophakic children. When you do a literature search, pseudophakic children seem to have better visual outcomes following surgery as far as compared to the aphakic patients. And this was especially true in children who had unilateral problems. Pseudophakic children did better. I found 2 studies with some long-term data only, again. This Terada et al., this was published in 2012, which had a considerably large number of eyes, considering the rest of the studies were all 6 eyes and 7 eyes. Again, it contained everything in uveitis. There was no clear-cut data on how many were JRA, how many were... But as a general in uveitic eyes with a median follow-up of 6 years, and they found both these studies, and another study by Gissens et al., which has again fairly good number, but basket case of almost everything in uveitis, they found good results in pseudophakic eyes. Both of them looked at pseudophakia with fairly okay follow-up. And both these studies stress the need for maximum control of inflammation pre and post surgery. But again, my problem here is again 6 and 7 years in the life of a child is not much. So perhaps if you are looking at the uveitic patients who are not JIA, it is probably safe to implant IOL in children, provided, there is a big provided, you have a strict control of inflammation and IOLs are in the bag. Now comes the JRA, the troublesome thing, because it's a really. Now there is a bit of a diagnostic dilemma versus, I think none of the UVI consultants have also ever come into the conclusion what is JIA versus what is JRA. JRA seems to be a more virulent form and does react very badly and often blinding disease in children. JIA is again immune-related arthritis, but there is probably a little difference between the two, how they behave. We don't know if they are problems in the same spectrum, more severe versus less severe, or they are two different processes altogether. No, this is something which, despite extensive talking to everybody, I have not been able to really find out. But there are several studies which really looked at cataract surgery in children with JIA, or what we call as juvenile immune arthritis, and it was considered a contraindication at least few years back. Either it was JRA or JIA, but in a recent study, they have shown again good improvement in visual acuity, but median follow-up was only 1 year. So this is our own data, which has come out from Shankar Netralaya. And she also had 7 cases, but some of them were adolescents. In this, they were again JIA and pseudoephysification. All of them improved. I think 6 out of 7 patients had a improvement in by at least 2 lines in the visual acuity following pseudophakia. But again, here follow-up was a little issue. Follow-up was just about 2 years. And their patients were older, considerably older. So if you look at the, if I were to put you together for you, it is still a relative contraindication, JIA. It's absolutely essential to control inflammation prior to surgery. Older children, again, or adolescents, are likely to do better with pseudophakia. However, there is a single exception. In young adults with HLA-B27 positive arthritis, probably it is still contraindicated to put intraocular lens there. No need to stress that in the bag is the ideal situation. Hydrophobic, or if you come to the material, probably hydrophobic acrylic or HSM lens is preferable. What we don't know, most of these studies were done before the biological agents were available, like etanercept and infliximab. Whether that changes anything from the cataract point of view, we have no studies or no literature on that as yet. So carry home message here is, use your best judgment as far as IOL is concerned. Complete and sustained inflammation control. Surgery is probably not the end of the road for these children. They still continue to need monitor for inflammation, visual axis, and you need to monitor, keep an eye on amblyopia as well as IOP as they go along in the life. So it's not over, even if unless the Lord says it's over. So that means lifetime. I'll leave you with Wasimuddin, who came to me when he was looking like this, had unilateral toxocara granuloma. After 6 years, he still has a granuloma. As you can see, vitreous is still not clear. He has 6/18 vision in that eye and fairly doing well as far as the IOL is concerned. I would also like to remind you there is a nice meeting coming up under the aegis of Shankar Netralaya, which deals with world ophthalmic anesthesia. It is on 3rd and 4th September this year in ITC Grand Chola in Chennai. You are all most welcome to attend. There is some very interesting things lined up from the anesthesia point of view. Thank you for your attention.